Good morning, everyone. Welcome to the Grand Rounds. And I hope everybody can hear me okay on the virtual side of things as well. So, very briefly, I chose this topic because I think we got a couple of cases when I was on service more recently, and I thought it would be good for the residents to review this. And it's a very basic presentation, mostly geared towards the teaching for these residents as well. So feel free to hop in, or if you have any questions, comments, please feel free to stop me. I don't have any disclosures. Um, so, with all my presentations, I really want to emphasize on the clinical aspect of the topic. So, I wanted to start off with this case that we saw when I was training in Boston, so a while ago. A 64-year-old female presented to the hospital after she was found down at home, unresponsive. Family last spoke to her about 2 days ago. She said she wasn't really feeling well, had a poor oral intake. The only history she had was of a history of bipolar disorder. Was taking Depakote 500 daily for that. By the time we got involved, she was already intubated, was on sedation with propofol. Brainstem reflexes were largely intact, couldn't really withdraw in any of the extremities. The initial CT head showed a large intraparenchymal hematoma on the right, parieto occipital region with extension to the ventricles. You could see due to the compression of the ventricle here on the right side, the posterior horn of the lateral, you could see the compensatory increase in the size of the left lateral ventricle as well. So pretty decent amount of hemorrhage. You could see the midline shift, some edema around it as well. Neurosurgery got involved. She underwent hemicranie. This is her post-op CT head with some improvement of the edema and the midline shift, but still significant compression of the ventricles and the ventricular extension. So her hospital course was complicated by intermittent left gaze deviation, rhythmic twitchings of the left face, arm, and leg. EEG was consistent with seizure-like activity or cortical hyperexcitability, PLEDS. She was initially started on Keppra, didn't really have much improvement, and then we added Wimpat, to which she responded quite well, both clinically and EEG-wise as well. The next day, we got an MRI that showed on the DWI, you could see some T2 hyperintensities with some vasogenic edema. You could see around the lesion on the flare sequence, GRE with significant hypointensity, suggestive of the bleed, as we saw on the CT as well. And there was not a lot of contrast enhancement on the contrast scan. Because this lesion was unusual, we obtained an MRV that showed, loss of filling of the right transverse sinus. The vessels were otherwise intact, and then eventually she was diagnosed with venous sinus thrombosis. Clinically, we started her on heparin drip, even though there was hemorrhage. We'll talk about that more. Our protocol in Boston was a little different than what we use here, a much higher PTT, goal of 60 to 70 with the stroke protocol. Her hypercoag workup remained negative. We did a CT chest, abdomen, pelvis, ruling out malignancy. And then she was eventually transitioned to Eliquis 5-BID. Couldn't really find any cause for her thrombosis. By the time I was there, we followed her up in the clinic. She was in a rehab facility needing 24/7 nursing supervision. She was trached and pegged, not really doing well overall. So, venous sinus thrombosis overall is a very rare disease, not as common, more common in women though, especially of childbearing potential and women who are pregnant, postpartum. We see a lot of cases, mostly postpartum in these population. There is an increased risk of having sinus thrombosis if you have any of these. So if somebody is undergoing a cesarean delivery, you have 3 times more odds of having sinus thrombosis. And if you are having hyperemesis during your pregnancy, then you're more likely to have sinus thrombosis as well. Any sort of infection can increase your risk, and also gestational hypertension can cause it too. This is according to the very old data from the Healthcare Cost and Utilization Project. So the venous anatomy is a little complex, so I wanted to spend some time on that. These are basically endothelium-lined channels within the dura. These are valveless, don't have any valves, unlike the arteries. And the flow really depends on pressure gradients, and we'll talk about that a little bit more. But that's why the degree of injury that you can typically sometimes see with sinus thrombosis is more devastating because there's so much pressure gradients involved. This is a basic anatomy. I know it can be challenging to identify these on imaging, but basically you divide the venous sinuses into either the superficial or the cortical sinuses, or more deep sinuses. Your deep sinuses more so involve the internal cerebral vein, the vein of Galen, a part of the straight sinus. Or based on the location, you can also divide them into lateral or midline sinuses. So your midline sinuses is your superior sagittal sinus that sort of drains into the confluence of sinus, your inferior sagittal sinus, your straight sinus, and the occipital sinus, which is not really shown here. So all of these drain into the confluence of sinuses. And on the lateral side of things, you have the large transverse sinus, the sigmoid sinus, that ultimately drains into to the internal jugular vein. For the residents, for your write and your board exams, you got to know what's in the cavernous sinus. So your 3, 4 cranial nerve, V1, V2, your 6, and your internal carotid artery. Very, very important to remember, because it's really helpful when you have a patient with cavernous sinus thrombosis. Based on your physical exam, you can basically localize it quite easily. So that's your cavernous sinus right there. It's sort of connected to the other side through the intercavernous sinus. So what is the frequency of venous sinus thrombosis? What sinuses are affected most? Typically, if it's a board related question, or if it's in your right exam, the answer would be superior sagittal sinus. That's according to the American Heart Association, Stroke Association, but you typically see a lot of transverse sinus thrombosis as well. And then multiple sinuses can be involved in up to 18 to 50% of the cases. So what causes venous sinus thrombosis, or what's the pathophysiology or the mechanism involved? The basic pathophysiology is that there has to be some sort of an obstruction of the sinus. And as I said, these are valveless structures, so the flow is really dependent through the pressure. So whenever there's an obstruction, that can cause an increase in the venous pressure and the capillary pressure, that ultimately leads to a decreased cerebral perfusion pressure, blood flow. And because these sinuses have very low autoregulatory capabilities, unlike the arterial structures, they tend to be more susceptible to this sort of injury. So whenever there's decreased cerebral blood flow, that will ultimately cause ischemia to the sodium-potassium ATPase pump, leading to the cytotoxic edema, and that's where you can see your venous infarcts and the edema that comes with this type of injury. How does the obstruction occur? So, very basic Werker's triad. So there has to be one of 3 things, or all 3 things, that needs to be involved. But it needs to be stasis or turbulent flow or any sort of hemodynamic changes that can then lead to your endothelial injury, dysfunction, and predisposing all of this. There has to be some sort of hypercoagulability within. So either a hypercoagulable state that is secondary to a genetic cause, or a transient cause, which we'll talk about more, or underlying malignancy. These are necessary for you to have the clot formation. When it comes to venous thrombosis, though, it's more of a dynamic process, right? So there has to be an impaired balance between procoagulant and anticoagulant properties. And, as we said, because these are so pressure dependent, and so, they don't have any valves, they tend to, the clot may propagate forwards, backward, or even affect multiple sites. And what is going to tell us what sort of injury a patient is going to have based on the thrombosis is really dependent on what we see with the arterial occlusions as well, right? So if when we're talking about arterial ischemia, If a patient has very good pre-existing collaterals, then the injury is sort of limited and not as bad. Same with the venous side of things as well. So if you do have good pre-existing venous collaterals, then you can expect a favorable outcome. And obviously, how much the thrombus is propagating and how much or how many sinuses or how many sites are involved will also affect the degree of injury. So what are the etiology and risk factors? So some of them we already spoke about, right? So pregnancy is one, but more commonly, you do tend to find a cause for venous sinus thrombosis rather than not find a cause. So more than 85% of adult patients, you tend to at least find something, a risk factor or an etiology for it. When it comes to children, it's more different, and we don't have a lot of data on that. The largest registry I could find was in the Canadian pediatric population, where they found that more than 98%, almost 100%, really did have a cause of venous sinus thrombosis. The etiology is really divided into two parts. So there's a septic cause and a non-septic cause. So a septic cause really depends on where the thrombus is. So if it's in the cavernous sinus, the infection sites can include periorbital, sphenoid, and ethmoid sinuses, or post-dental procedures and stuff. If you're talking about lateral sinus thrombosis or more transverse sinus thrombosis, and the infection can spread from mastoid air cells to epidural space and then through the different veins. If now we always run into issue because there are two transverse sinuses, one can be sometimes dominant, the other can be non-dominant. So if your dominant transverse sinus is involved or thrombosed, then you are talking about more devastating presentations like hydrocephalus and larger venous infarcts and stuff. The superior sagittal sinus, which tends to be most often the case, is really as a result of either bacterial meningitis, frontal sinusitis that can spread, and again, because you only have one of these, if it's a complete occlusion, it's mostly fatal, and it can also cause communicating hydrocephalus. So the septic causes tend to be less less common as compared to the aseptic ones, especially in our population that we see in the hospital. The aseptic ones, as we spoke about, the most common ones are the OCPU, especially with the estrogen or pregnancy or recent pregnancy tends to be the highest association. Now, the Dutch group has looked into this in much detail, and they really found that in their cohort of patients, about 85% of women who were childbearing and ended up having venous sinus thrombosis. Approximately 85% of them were actually on OCP. So that's one very important piece in the history that we need to concentrate on. Obviously, some other hypercoagulable disorders like protein CRS deficiencies, most commonly we see in our population either factor V latent mutation or antiphospholipid antibody syndrome as the most common cause. Some rare autoimmune diseases. One thing that I really wanted to talk about was inflammatory bowel disease, because I have seen a lot of patients with ulcerative colitis. They tend to be hypercoagulable from the disease, and they present with venous sinus thrombosis as well. So something to keep in mind at the back to look for these things. Other etiologies, malignancies, chemotherapy agents like asparaginase, tamoxifen, cisplatin, all of these eventually make you hypercoagulable and will increase your risk of both arterial and venous thrombosis. Recent head trauma is also a very important risk factor for thrombosis. A recent LP that can cause sometimes intracranial hypotension. All of these are related as potential etiologies. This is a nice table that sort of summarizes the etiologies into two parts, either transient or chronic. So you have your OCPs, pregnancies, your hormone replacement therapies, which are probably the most common ones. COVID-19 is in there as well. Dehydration is something that we see. We can probably chalk onto it because if we don't find anything else, and if you dive it deep down, like the patient I just presented, we really thought this could have been secondary to dehydration because she had poor PO intake for the last week or so. and we couldn't really find any other cause. The more chronic ones, you have your obesity, anemia, other malignancies, and your hypercoagulable states. With COVID-19, so, we started seeing these more back in 2018, 2019, 2021, the time period when COVID was at its peak. So we still don't have a lot of data, but the largest observational study we found was published back in 2021, did find a fair bit of patients who had COVID, and because of the thought that is hypercoagulable, these patients did present with sinus thrombosis as their first presentation. The thing with COVID and all the vaccine-associated thrombosis is that your hospital mortality is very high. So almost 40% of these patients had a high mortality. Now, this could have been secondary to the fact that, the treatments were not as advanced at that time, the vaccines were not in there, and, was it secondary to the COVID itself or the thrombus? Hard to say. All the three vaccines did show some association with, in thrombotic thrombocytopenia that was, causing venous sinus thrombosis as well. These were typically seen in younger patients with fewer comorbidities. And again, the mortality rate remained very high if you were having thrombosis secondary to these causes rather than CVT from other causes, which is just 3 to 5%. So there was a substantial difference between the two. Obviously, you can do $1 million workup and still find nothing. Like with lots of strokes, about 50% strokes remain cryptogenic. But that's not as common with venous sinus thrombosis. You do tend to find something or the other as a cause. So, but still, there remains cases where you don't really find anything, and then those are the ones that you say cryptogenic. Does anybody know the answer to this? Wild guess. Who? 34. Dr. Freeland, Okay. Actually, it was Hillary Clinton back in 2012, 2013. She apparently had some sort of a concussion, had a viral illness, hit her head. She was also having poor PO intake, I read. So they chalked it up to concussion or head trauma that I spoke about, but she also had flu and dehydration. So I'm not sure if she's still on blood thinners or not, but she was placed on blood thinners at that time. Okay, so what are some of the signs and symptoms that these patients can present with? So this has a very wide variety of symptoms, right? So obviously, if there's a venous infarct, if there is involvement of multiple sites, then you can see, signs of isolated intracranial hypertension, focal syndromes like seizures, weakness, numbness, arms or legs, typically like what you see with the arterial strokes. And so the Dutch European study actually looked at the presenting symptoms in their population, and this is actually consistent with what you should see overall as well. So if it's in your board and if it's on your right exam, the most common, it's also in the clinical presentation as well that we see, headache is probably one of the most frequent causes these patients present with. And the second most common, I remember it showed up on our board, was seizures. So seizures is the second most common presentation that you can get with venous sinus thrombosis. Obviously, if you have signs of increased intracranial pressure, then you can have papilledema, impaired conscious level, and patients can be comatose as well. So a very wide variety of symptoms it can present with. And based on the location, so if it's, internal cerebral veins, your vein of Galen or your straight sinus, then you can have your deep cerebral thrombosis, and that can present with, your brainstem symptoms, your thalamic, bilateral thalamic symptoms, as well. And if your cerebellar veins are involved, then obviously you can have the posterior circulation signs too. Now, there is no single lab test that you can do to identify sinus thrombosis. Obviously, you get the basic blood work when somebody comes in, but your other blood work, what you want to do is really dependent on what you're thinking, right? So what's the cause? So if you want to send a hypercoagulable lab work, if you're wondering about malignancy, then those sort of tests are really based on what the clinical presentation is as well. Now, imaging can be really challenging, and imaging can be challenging because there's no one clear symptom that you can point to saying that this could be venous sinus thrombosis. So it's really dependent on what you're thinking at that time when you've ruled out other things. But imaging in general can be challenging, especially at our level here. But obviously, everybody gets a CT. Everybody tends to get an MRI as well. These are one of the two most common tests that you're going to show you the thrombus. You can, in these images, have a direct visualization of the thrombus. You can see absence of venous filling. And obviously, if the degree of injury is bad enough, then you can obviously see venous infarcts, hemorrhages, and some dilated veins at the vascular level as well. So your non-contrast CT, the problem with that is that it can be unrevealing in about 25–40% of patients. And to be honest, nobody's really looking for a sinus thrombus on a head CT as well when somebody comes in with even, let's say, focal presentation. You're more so looking at the arteries, you're more so looking at, the tissue level, if there's a large infarct or not. That is why CT with contrast is essential, or any image with contrast is really what you need for sinus thrombosis. However, even on the CT head, if the degree of injury is very large and you have multiple infarcts, the characteristic would be that it's not really following a vascular territory because it's a venous infarct and it has ill-defined appearance. Remember the image that I showed you? It's not a classic wedge-shaped infarct or everything. And one thing always to keep in mind is if you have bilateral thalamic involvement or bilateral basal ganglia involvement, always think about venous infarct. I know you can talk about arterioperturon and all of those type of strokes, but always keep venous sinus thrombus in mind as well. So these are some of the images that you can see on a non-con or type, the thrombus that you can see on the non-contrast scan. So there's in image A, there's a hyper density here in the superior sagittal sinus. There's a dilated vein here that it can also light up. This is what you call a cord or a dense sign. Again, this is so non-specific, right? If you're not really thinking about it, then this can be easily thought of as a calcification or a very non-specific sign. Here you have a dense delta sign, which is really a triangle that forms due to the thrombus within it. Again, very non-specific, but something to keep in mind when you're reviewing the CT heads. And here, when you talk about with contrast scans, this is your mostly your CTAs or a CTV. You can see what you call an empty delta sign. So there's a thrombus that is corresponding to the hypodensity here and surrounding hyperdensity where the contrast seems to be filling okay. This is perhaps the most important sign that you need to look for in imaging when you're talking about venous sinus thrombosis. CTV, here you can see the transverse sinus on the left filling up quite well. On the right, doesn't really seem to do it as well on the left side, and then there's some distal flow through it. A CTV is probably a better test than a CT head just to see the thrombus itself. But studies have shown that if you combine a CT contrast with a CTV, then you have a very high sensitivity and specificity to pick up venous sinus thrombosis. Obviously, MRI remains your gold standard still. You have your GRE sequences or SWI sequences, your with contrast scans that will help look at the thrombus in better detail. These are some of the examples. So this is your SWI here. You can see a hypo intensity here within the left transverse sinus that denotes an active thrombus. You have decreased filling with contrast here, and you have loss of opacification or loss of flow in the jugular vein here, denoting that this is most likely an active thrombus that's sitting there. Same here. Your MRV is probably one of the better tests that can differentiate or help you pick up the venous sinus thrombosis here. The other thing that's very important is that you can typically get, as I was talking about early, was hypoplastic sinuses, and how do you differentiate whether it's a hypoplastic sinus from birth or it's an active thrombus or an active occlusion, and your MRV helps to differentiate that. So whenever you're not sure with a CTV, either these are arachnoid granulations or this is a hypoplastic sinus, always obtain an MRV. Okay. These are some of the typical lesions that we can see with venous thrombosis. As I was talking about bilateral thalamic infarcts, unusual appearance, always look for a sinus thrombus. Same here. So you can see some good flow through the straight sinus, but you don't really see anything beyond it. And on the flare here, you have this lesion here, which is not really entirely following a vascular territory. It's a very odd shape, not the classic wedge-shaped infarct that you would see with the arterial strokes. And here you can see bilateral frontal infarcts. That's probably due to the superior sagittal sinus thrombus. It's pushing the structures to the other side because of the edema as well. And same here with the MRV, you can see the active occlusion here on the superior sagittal sinus. Now, probably the best test would be a conventional angiogram to see if someone has venous sinus thrombosis or not. Typically, we don't really concentrate on the venous sinuses on a routine diagnostic angio, but you can always go back and look at the images and see if there's prolonged contrast that's flowing through the sinus, or if there's any dilated tortuous veins that are showing up as well. If you're specifically looking for it, then looking for venous sinus thrombosis, then these are typically reserved for patients who are actively crashing in front of you. We'll talk about that more in a little bit, but typically not all venous sinus thrombosis need a conventional angiogram to look for thrombus. So as a summary, your CTVs and MRV are probably the best test that you can look at. MRV is more helpful in sort of differentiating a hypoplastic sinus from an active occlusion. And contrast is the way. So whenever you're worried about sinus thrombosis, you have to have a contrast scan that's going to significantly increase your sensitivity and specificity. So what are the treatment goals, right? So obviously, if somebody is coming in with venous sinus thrombosis, you're thinking at recanalizing the sinus, decreasing the spread of the thrombus or causing thrombus at other sites based on what etiology you find, right? So I would highly recommend all the residents to look and read through this recent paper that was published, not actually recent, it was back in 2024. The AHA and ASA came up with a scientific statement on how to diagnose and how to manage these patients. It's a very well written, very easy to understand paper, honestly. And I took a lot of stuff from this paper too. So your treatment is basically divided into two types. So what to do in the acute phase and what would you do in the more long-standing or chronic phase. So in the acute phase, we all know, anticoagulation is the way to go with low molecular weight heparin, depending on the patient situation or clinical scenario. Keeping in mind, even if somebody is coming in with an intracerebral hemorrhage that is secondary to a venous occlusion, this is not a contraindication to start blood thinners. So you should not be worried, because we have enough data that has shown that this type of hemorrhage does not get worse with starting anticoagulation early. So, there was German and Dutch trials that looked at this specifically. The problem with these trials is that the disease itself is rare, so the sample size is not that great. But none of these trials actually showed that your hemorrhage was going to worsen with starting heparin early on in these patients. And obviously there was not a significant, a reduction in death and disability too, but it did help with recanalization overall and preventing more clots from happening. Which one to choose? We typically use low molecular weight heparin because it's well studied. And one of the studies back in 2012 in the UK showed that there was zero hospital mortality with low molecular weight heparin as compared to unfractionated heparin. And actually, these have been supported by a lot of other clinical trials as well. So what to do after the acute phase is over and the patient is more stabilized. So the recurrence rate for CVT is about 2 to 7%. And most of the problems that arise is because based on the etiology, you start to form clots, elsewhere. So pulmonary embolism, for example, or, deep vein thrombosis in the legs or the pelvis. What should you use for anticoagulation. So this has been a subject that has been looked at extensively. I know, the residents recently had a journal club that specifically talked about which agent is better. So up till 2015, 2014, when the DOAC started taking over, we were more so keeping or putting these patients on warfarin, thinking that that would be the best medication to go about. But with DOACs getting popular, there have been a number of trials that have looked at whether warfarin is superior or whether DOACs is better in these cases. So RESPECT trial was one that randomized patients to dabigatran and warfarin, and they didn't really find any significant difference in the two arms, and not much of in terms of hemorrhage as well. Same with rivaroxaban or Xarelto, the secret study didn't really show any significant difference in outcome between warfarin and rivaroxaban, but there was a slightly better bleeding profile with rivaroxaban. That's what we actually see in our arterial strokes as well. Perhaps the largest study or trial was the more recently concluded, the ACTION CVT. So ACTION CVT basically took into account rivaroxaban, dabigatran, and apixaban as well, and compared it to warfarin. So this was a more prospective observational study. They followed these patients for 1.5 years, and they imaged these patients again to see whether the clot had recanalized or not, or whether there was new stroke, or whether there was new occurrence of thrombosis elsewhere. And they did not find any significant difference in rates of recurrent VTEs among the three groups. Basically, they were non-inferior to warfarin. So also pushing us to use more of the DOACs in this subset of population. But does that mean that all of this is applicable to our current scenario and the current practice? And there was a paper that was published that specifically talked about it. Very interesting paper if you guys would like to read more. But basically, what it says is that we do have good data now to suggest using DOACs instead of warfarin in these patients, just like other scenarios with atrial fibrillation and strokes, etc. But there are cases where we still don't know what to do, right? So not everyone is eligible for a DOAC. Cost is an issue, obviously, but you can also, special cases like antiphospholipid antibody syndrome, malignancies, some other genetic conditions, what to do in those cases, pregnancies, breastfeeding. DOACs are actually contraindicated in those. So what to do with those? Also raises, questions whether we should heparin bridge these patients. If so, then what is the correct, therapeutic window, therapeutic protocol that we should be using? All of these are, unanswered. We talked about that, so DOACs are contraindicated in pregnancy, breastfeeding. Heparin is the way to go. Also, now more and more data is coming out that DOACs are actually helpful or equally beneficial in cancer patients when compared to warfarin. So that is an area that is still under the works, but more convincing data is coming out now. So basically, what you should do is obviously the shift is now towards using DOACs more instead of warfarin in these patients, and we have, I think, enough data to support it. But also, you should make sure that you're basing the decision on individual clinical scenario, and involving hematology, for example, and multidisciplinary teams before making that decision if there's a conflict. How long should these patients be on anticoagulation really depends on the cause, right? So if you have a provoked CVT, a transient etiology for the CVT, then 3 to 6 months is typically okay. For ones where you don't find a cause or unprovoked, then it's really continued for 6 to 12 months. And depending on the etiology, if somebody has hypercoagulable disorder, then typically these are continued lifelong. What's the prognosis? So prognosis overall is very good. So if about 60 to 80% of patients have full recovery, less mortality rate as compared to the ischemic strokes and stuff. but still it's less than 10%. What are some of the negative prognostic factors? If it really depends on the presentation. So if you are coming in with focal deficits, if you have malignancy, if you're comatose, then all of those are poor prognostic factor. Remember the case that we spoke about, she had all of them. The other also, one of the poor prognostic factors, if there are multiple sites involved. So if more than two sinuses are involved, then that will go towards a poor prognosis. So this is a case that I wanted to sort of mix it with what I was going to talk next in terms of treatment. So this is a more recent case I saw here. So a 29-year-old male came in with a 2-day history of headache to Mary Elizabeth Hospital. No other focal deficits, exam completely benign per the documentation. He initially got a CT head that did not show any acute findings. He had a CTA head and neck as part of the, looking for aneurysms, etc. And there was a concern of right transverse sinus thrombus on the CTA. We then did a CTV on him, and it showed, extensive thrombosis involving sagittal, transverse, and sigmoid sinuses, also extending up to the jugular vein. He got an MRI, did not show any venous or arterial infarcts or anything else abnormal. He was admitted for observation. He was started on a heparin drip at that time. This is the best picture I could get, actually. So you could see some flow through the left transverse sinus, but you don't really see anything here. Even here, you can see flow through the straight sinus, but the superior sagittal and the inferior sagittal don't really light up. So again, that was the best picture, but if you look at all the images, it was difficult for me to put it in, but you could clearly see the clots there. On the second day of admission, we were called again because he worsened. So he was found to have left-sided weakness, right gaze deviation. On code stroke evaluation, his NIHS was 14. We got a repeat CT head that didn't show any bleed, didn't show any evolving infarct. And at that time, we had a discussion with our interventionalist, and we decided to transfer the patient to U of L to perform an angiogram and see if there's anything that we can do. This is the pre-treatment angiogram. So you can see some good flow on the left. So this is your venous phase. So you see some good flow through the the sinuses here, not as well, but just as a comparison, you can see nothing flowing through here. And obviously you look at the right MCA whenever you have an MCA syndrome, and the MCAs were filling in well. You could see a better sinus here on the left side, and you don't really see that here. So unfortunately, these were the best pictures I could get. But this is what we ended up doing. So what we did a thrombectomy, or I didn't do it, the interventionalist did it. They did a thrombectomy of your jugular vein, superior sagittal sinus, your transverse sinus, and then they stented the jugular vein to keep it open. So this is not very commonly used. And you can see post-stenting a good flow through the superior and the transverse sinus as well. He got a repeat angiogram a week later, and it was all patent. So very interesting. How did this patient do clinically? So he was extubated the next day. His NIHS was 0, back to baseline, continued to complain of headaches, but overall did very, very well. Did not have any seizures. On workup, he was found to have antiphospholipid antibody positive. He was started on warfarin, or really heparin to warfarin bridge. He was seen by a physical therapy, did not recommend any sort of rehab, even home rehab. He was discharged home day 5. I just saw him in the clinic, and he's doing excellent. He's on warfarin now still, but he has no deficits and is overall doing very, very well. So is endovascular reperfusion an answer to these patients? Well, not a lot of studies have actually looked into it, but the largest one was a TOACT trial, which was more so Brazilian based. This was, I think, done in 2015 to 2021. It randomized patients to endovascular therapy versus medical management, and these patients needed to have at least one poor prognostic factor. So either they were crashing in front of your eyes, they had focal deficits, encephalopathy, or coma, or something like that. And what they did was they did mechanical thrombectomy plus either an intrasinus application of IV-TPA or urokinase or a combination of both, depending on what the interventionalist felt was appropriate. And they actually did not really find significant differences in the overall, outcome. But the mortality rate, unfortunately, with patients undergoing an endovascular treatment was higher. Could have been because obviously these patients were significantly more sick overall. Still more and more data is coming out. There have been more observational studies, more case series that have shown some benefit in these patients, but that is really reserved now for patients who are crashing right in front of your eyes and you don't have anything else to offer, or these patients who are coming in with focal deficits. They are the ones who you should definitely consider endovascular treatment on. The good thing about these procedures is obviously when you're taking the clot out, then you have a higher chance of having a good recanalization rate. So what are the recommendations? So the European Stroke Organization, I mean, these are nothing fancy, honestly. I mean, they recommend to start anticoagulation with heparin as soon as you can. Even if it's intracerebral hemorrhage, this should not be a contraindication. In terms of endovascular therapy, they don't recommend exposing all patients to it, but patients who are very, very sick have one or two, bad prognosis factors. Same with your American Heart Association and Stroke Association guidelines. Didn't have anything different to add, but they also recommend starting anticoagulation as soon as possible. So to summarize, CVT is is an uncommon cause of stroke. Most commonly, occurs earlier than patients who come in with arterial strokes, which is around 50 to 60. The mean age of onset here is 39 years. Most commonly seen in, postpartum women who are in OCPs, have a hypercoagulable state for any reason. Headache is probably the most common symptom. And depending on how the degree of injury, the presentation can be different. Your CTVs and MRVs are probably the best test to get. If you're unsure, conventional angiogram can help, but it's mostly reserved for patients who are super sick. There is push to start anticoagulation as soon as you can, even with hemorrhage. And after the acute phase is over, you can always switch them to DOACs. Now, there are cases where you don't see an infarct, the patient is otherwise stable. There's an argument you can always directly switch these patients or put these patients on DOACs rather than doing the heparin transition. But we still don't know about what to do with chronic kidney disease patients, those with antiphospholipid, other hypercoagulable disorders. Probably warfarin is beneficial in those cases. I wanted to leave you with this very interesting story for this patient, Naomi, who delivered a beautiful baby boy back in 2023. She always had a history of migraine, but 2.5 weeks after the delivery, which was really uncomplicated, she started having the worst headaches of her life. She went to an urgent care, was discharged home, saying this is all migraine related. But her midwife the next day saw some focal deficits, right-sided weakness, facial droop. She was rushed to the ER. They did further imaging and they found she has extensive venous sinus thrombus. So, she has been advocating for stroke patients overall, and her motto is really, whatever type of stroke you have, BFAST is what you really, really need to know. Whether it's venous, arterial, always come to the ER, call 911 for anyone who, notices these symptoms and everything. Regardless of whether it's just a headache, whether it's just a facial droop, you gotta come to the ER soon enough. So that is always related to a better outcome. It's always a team effort. We need to, update these pictures. These are old, but we're doing quite well here in the stroke center here. So I'm open to questions if anybody has any. Yes. Mm-hmm. Mm-hmm. True. True. And I think that's a good point, and I think that's same with the arterial strokes as well. I think we don't really do a great job in looking at the pathology of the thrombus, right? So if somebody's coming in with an MCA occlusion, I think if we can, for example, send out these specimens for pathology, that can answer where the etiology is coming from. So is it coming from the heart or somewhere else in the body? So I think that's a good point, and I think that's I don't know if there are already studies that have looked into that from the pathology aspect of things, but something to definitely look at. Right. Mhm. Yeah. Yeah. So they specifically excluded patients who were like they were found to have, let's say, a hypercoagulable state from antiphospholipid. They were excluded because they used to be on warfarin. Also, patients, female of childbearing potential, malignancies, they sort of excluded that. So, correct, 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 correct. Right. That's why we don't know what to do. I mean, with malignancy now, there's a push to do DOACs because some of the trials have shown benefit or at least non-inferiority to warfarin or Lovenox. But yeah, but they excluded it from the trial. Yes. Uh, I mean, when they didn't get a lot of patients, right? They only had like 60 or 65 patients in the study, and they may have been stopped. I don't know about the exact detail, but the results were not really encouraging. So they may have stopped it at the end. I would still anticoagulate. I don't know. I don't think there's a right answer. I would push to anticoagulate, but I don't know. Yeah. I don't think there are lots of studies. I mean, it's rare, right? So it's difficult to study these, but yeah, my gut feeling would be to anticoagulate. There's a clot that's coming from somewhere. So, yeah. Yes. Oh, really? Okay. So I know all the axial, more coronal and sagittal, right? I agree. Do all. I think it also depends how you order it. I think if it's a code stroke CT head, then I think there's an urgency, and I think some of the views may be missed. But if I'm not wrong, I think all the code strokes do have axial, coronal, and sagittal views. CT, not the CT heads, not always. Yeah. It's variable. Yeah, right. Yeah, I don't know how long it probably. Yeah. Mm-hmm. Yeah, that's true. So typically we don't use contrast for strokes, right? So if you're just looking for stroke evaluation or ischemia or an arterial infarct, you rarely use contrast. It starts to enhance. So generally what I was told was uh, 3 weeks and 3 months. So you start to see enhancement 3 weeks after the stroke, and the enhancements would typically go away 3 months after the stroke. With the venous, occlusions, it can vary, but as I said, it really depends what the extent of injury is and how much disruption there is of the blood-brain barrier, right? So if the venous infarct, if there are multiple sites and there's a lot of edema, then you should typically see more enhancement. For the more subtle ones with more smaller ones, typically you would assume it's still cytotoxic edema. And in those cases, you should not typically see enhancement, but there's no general rule. Um, but for CTV and MRVs, if there is an active thrombus, then you can see a hypointensity that denotes the thrombus, and then surrounding hyperintensity that would be more suspicious of the clot. But in the intraparenchymal side of things, it's variable. It really depends on the degree of injury and what type of edema is really there. That's your answer. So Dr. Sarai is asking if there is any study that has compared um, DOACs with one another, and there's nothing when it comes to venous sinus thrombosis. Most of them have compared warfarin with the other, but there's not a study yet that I'm aware of that has compared the DOACs. There are meta-analysis when it comes to ischemic strokes, where apixaban has a better bleeding profile and better, um, uh, mostly with the bleeding profile. It's as comparable to even as aspirin, so it's relatively safer than rivaroxaban or dabigatran. I know with the atrial fibrillation studies, but not too much about the sinus thrombosis. Derica is going on as usual, and she has a question. She says, if a patient comes in with headache and is stable with venous thrombosis and CT shows no bleed and MRI shows no stroke, do we start them on heparin drip or start any DOAC? So this is, again, your individual preference. We were taught to just go directly to DOAC. There's no point in doing a heparin bridge in these patients. Generally, there's no good data about heparin bridge, even for ischemic stroke or arterial stroke patients who have AFib, etc. As well as just that it makes us feel better more than anything else. So if there's nothing on the imaging to suggest that the patient may be a high risk for hemorrhage or anything else, then I would just jump to a DOAC, especially if the patient is clinically very stable. All right. Yes. Like with the cost and stuff. Yeah, so if you look at the trials, especially atrial fibrillation, arterial stroke trials, um, dabigatran still had a comparable bleeding risk when they compared it to warfarin. Out of the all three, dabigatran probably has the highest bleeding profile. It's also a BID dosing, and kidneys can affect the dose too. So a little bit tricky, but if it is generic and it's I would still prefer it over warfarin for the stroke patient. So I wouldn't have a problem, but I would probably have to counsel them that the bleeding risk would still be on the higher side. And that bleeding risk is not just your GI hemorrhage, but also the intracerebral hemorrhage too. So it does have a higher risk of bleeding. Cool. I think we're good. Thanks.